Did you catch Ontario Health Minister Sylvia Jones's comments last month? When asked how she intended to deal with the myriad problems affecting the province's healthcare system, the minister said, quote, "After decades of inaction, we can no longer stand by and support a status quo that cannot respond to the current challenges the sector is facing." What exactly does that mean? No one's exactly sure, but it probably means allowing more private players to offer publicly insured services. And if so, is there anything wrong with that? Let's find out as we welcome, in Kingston, Ontario, former Federal Health Minister Dr. Jane Philpott, now Professor and Dean of the Faculty of Health Sciences at Queen's University. In Hamilton, Ontario, Dr. Bill Oravan, Vice Dean, Clinical Services and Commercial Enterprises in the Faculty of Health Sciences at McMaster University. And in Oshawa, Ontario, there's Natalie Mehra, who is the head of the Ontario Health Coalition. And we are delighted to welcome you three back to our airwaves. And as we occasionally have to do from time to time here, let me at the outset say, in the interest of full disclosure, my wife is a health policy analyst. She deals with these issues all the time. And we put that out there in the interest of edification or whatever. Okay, Dr. Oravan, let's get you in here first. If the Ontario government is, in fact, looking to get more private delivery of publicly insured services, tell us what that actually means. What does that look like?
Sure. So I think that's absolutely the right thing to do. We've been discussing this now for a number of years. I've watched the healthcare system deteriorate. I've been in this healthcare system now for 4 decades. I've seen successive deterioration. I think there's no question that the pandemic has shone a light on this, showed the deficiencies in the system. But even before that, we were operating in a situation where most public hospitals were at or above capacity. And we simply need to add real capacity to the system in order to keep up and in order to accommodate the growth in population, the aging that we'll see. I think if one of the best solutions in this is to allow more private operations to provide physical facilities and to attract back to the profession a large number of healthcare workers who have left the profession earlier than they planned because of the stresses induced. And now we're finding that even though we have millions of delayed interventions or investigations, we can't keep up with the new problems that we're facing, let alone address that. We need to have additional capacity. The private sector can provide it. We can pay for it out of the public system. You can present your OHIP card showing that you're an insured person. That OHIP card pays the doctor's fee. There was some negotiation that needs to be done around funding the actual operating costs of those facilities, but it can be done, as has been shown in a lot of jurisdictions in the world. And as Mr. Legault, for instance, in the ongoing election campaign in Quebec, has promised to build up to 12 privately owned, privately operated facilities.
I'm going to come back to that in a second.
Public.
Okay, let me stop you there because you've put your position on the record very well. Dr. Philpott, let me get you in here and say, if the Ontario government decides that it wants to have more private players providing publicly insured services, what would be your view of that?
So, Steve, you know I'm going to slightly frustrate you here because I think that we have to have a nuanced response to this question. I think the question itself can be a bit of a distraction, and we need to define some terms first in terms of what we're talking about when we talk about private healthcare, whether it is private delivery of healthcare or private payment of healthcare. And then, of course, even within private delivery, you've got private for-profit and private not-for-profit. So there's a tremendous amount of misunderstanding about what terminology we're using, and I think it's really important to be able to have those conversations. I've told you before, I am not fundamentally opposed to private delivery of healthcare because, of course, I'm a family doctor, and most family doctors in the province, if not, and as well as the country, are private practitioners. In fact, they're private for-profit practitioners, but they have obligations to ensure that for medically necessary care, that has to always be publicly funded and that people can't access care based on private pay for medically necessary services, it has to always be done on the basis of medical needs. So I think that it is unhelpful for us to be ideologically entirely opposed to private delivery of care, or ideologically in favor that is going to solve all our problems. I think it is neither the whole solution. There are a whole range of other really important solutions, nor is it something that we absolutely shouldn't be open to discussing.
Okay, appreciate your nuanced take on that. And Natalie Mayer, let's go to you and say, same question. Again, if the Ontario government, in its wisdom, decides it wants to have private players provide more publicly funded services, what would be your view of that?
Well, I think we have to be clear that they are actually already doing it, first off. And second off, I think it's pretty clear what we're talking about. The new thing is that the government wants to hand over money to private for-profit clinics that operate sort of as mini hospitals to do surgeries and diagnostics. They announced that, I think, quite clearly in August. And according to the Financial Accountability Office of Ontario, they actually are already doing it in the last quarter of last year. So the period ending April 1st, they doubled the quarterly payments to the private clinics to increase their surgeries and diagnostics. So that is the for-profit privatization of services that were heretofore offered in our local public hospitals. It's quite different than a family doctor who operates in a group or on their own. These are for-profit companies that run these clinics. And I think the other thing that has to be clear is that we have called all of the for-profit clinics. I mean, they have moved in some parts of Canada more than others to take over public hospital services. And each time we've called them, and we've called them multiple times, we've caught the majority of them, not a small minority, but the majority of them violating the Canada Health Act and charging patients outright for surgeries and diagnostics, as well as selling a whole raft of additional add-ons, medically unnecessary services that they charge money for, because that's how they maximize their profits.
So can I just understand, Natalie?
And they bill patients on top. Sorry.
Can I just understand? So your prime objection to going further down this path is the notion that patients will have to pay out of their own pockets in order to avail themselves of these services. Have I got that right?
I think the biggest fear is that we will not be able to preserve single-tier public Medicare in this province or this country if the Ford government continues with its path of privatizing our hospitals. But there are other issues too. For example, quality of care. I mean, we just had a horrific expose of what has happened in for-profit long-term care in this province and across Canada. There are serious quality issues in the private clinics. In addition, we have the most severe staffing shortages, really truly unprecedented, that we've ever seen. We can't actually have MRI techs and CT techs, nurses, et cetera, taken out of our local public hospitals to serve only the lightest care, easiest care, profitable patients in the for-profit clinics, leaving the heavier care patients behind with less funding and less staff to provide for them.
Okay, let me stop you there.
We have all kinds of unused capacity in our public hospitals.
Okay, let me stop you there, Natalie, because you've made 3 or 4 points here that I want to give the other two a chance to comment on. Okay, Dr. Orvan, you've heard about concerns about preserving the single tier, the quality of care, patients having to go into their pockets to pay extra money, staffing shortages. Are all these legitimate concerns with more private players, even if they're providing publicly funded services?
And there are concerns, but I think they can be easily managed within a private system, just as they are, or as we've tried to do for years within the public system. I mean, the reason so many people took early retirement and the reason we're having such a huge human resource problem is that people were stressed beyond belief and wanted to leave the public system simply because of those stresses. The ministers have said, both the previous minister and even the current minister, that what we should be doing is provide the right care at the right time in the right place. And that means that low acuity procedures that can be done in a private clinic, expand the facilities, the physical facilities, and the availability of staff should be moved out of public hospitals. There's no sense. For instance, here in Hamilton, where I work, our major cancer hospital has over 50% of its surgical volume is based on benign orthopedics. Total joint arthroplasty is not something that should be done in a major public hospital. It could easily be done in a freestanding, purpose-built, purpose-operated, private or jointly private and public facility. So that's where we're not interested in depriving public hospitals of anything. What we are interested in doing is improving the care for the patient. We've talked in this country about patient-centered healthcare for decades, and it's never happened because we worry about what impact it will have, probably none actually, on public hospitals, what impact it will have on the single-tier system, probably none. We're talking about public funding of private provision. All doctors in Ontario are private providers. We are not employees of the government. We are paid by public funds, just as we're proposing these private hospitals would be paid. We've had private hospitals in Ontario for decades. Shouldice is one. There are several others that were put out of business many years ago, but some have continued to thrive. I ran one of them, actually, the Don Mills Surgical Center, for a number of years in the early part of this century. We provided quality care. We were remunerated by the public system, and patients did not have to pay out of their pocket for anything other than what they would have to pay if they were in a public hospital.
Okay, let me get Dr. Philpott in here. You've heard some of the concerns that Natalie's put on the record. Let me get you to address those if you would.
Well, I think the anxieties or concerns that Natalie raises are absolutely legitimate and things that we need to think about, and this is an important conversation to have. Human resources is our most significant rate-limiting step now. In addition to a few other things that I won't go down the road of in terms of the strength of our primary care system. But so we do need to make sure human resources are available for medically necessary care. And I think when you look at the potential for barriers to be put in place that will allow people to jump the queue by privately paying for publicly funded services, that is one of the most obvious concerns that we have. Will people flee publicly funded systems to be able to go to privately funded systems? So that's absolutely a reasonable thing to put on the table for discussion, and that's one of the reasons why public pay for medically necessary care is such an important topic. Having said that, there are all kinds of really important parts of our health system that are not publicly funded because of the way that the Canada Health Act was established. So it was written now, its 1984 version decades ago. Its roots are more than half a century ago, and it was done at a time when most care was delivered in hospitals and most of it was done by physicians. Now, all kinds of things that physicians previously did can be done as well or better by other parts of the health system, and much of healthcare that was previously delivered in hospitals is now being done in clinics. So that has totally changed the face of what healthcare looks like. We do need to modernize and update the Canada Health Act. And where I'm really concerned is about some of the most important parts of our system, like mental health care, like home care, like primary care, that are not protected by the Canada Health Act. And that's where we often are most at risk of being able to see that there's not sufficient public support, and where people actually have a barrier to accessing care if they don't happen to have private health insurance or the personal ability to be able to pay for those really important parts of their health care.
All right, Natalie, let me ask you what I hope is a logical follow-up here, which is that certainly because of COVID, there have been additional stresses on the healthcare system that are really profound. I mean, we've heard about the diagnostics backlog that could take more than $1 billion to resolve. We've heard about canceled surgeries and tests that people are waiting longer and longer for. Question is the Ontario government capable of increasing the volume of publicly funded services provided to patients if they don't get more private players into the system? What's your view?
Of course they are. I mean, every large hospital, the last audit that the provincial auditor did found that every large hospital in Ontario has operating rooms that are closed for days or weeks or months at a time every year, or even permanently, because they didn't have enough funding to run them. This is pre-COVID. That continues, and now we have these very severe staffing shortages in public hospitals, to the point where at this point I was just talking with the chair of the Hospital Professionals Division at OPSU, the union that represents most of the health professionals in hospitals across the province, and she was telling me that we have MRI machines that are closing down overnight in our public hospitals because they can't get MRI techs. So you tell me, where is the staff going to come from to staff new private clinics that are being funded? They get facility fees and physician fees on top of the OHIP billing. And the evidence is that the majority of them extra bill patients on top, significant amounts. In fact, the majority of them violate the Canada Health Act and charge patients for their surgeries and diagnostics illegally. Many of them actually double dip, billing both OHIP and the patient as well for their surgeries and diagnostics. That's a higher cost, not a lower cost, certainly to the patients. And it imperils single-tier Medicare, and most of these people, of course, are seniors who are patients going to these clinics. So they pull the staff then, the existing MRI techs, out of your local hospital. The MRIs have to reduce their hours in your local public hospital, and the only patients that they can serve in the private clinics are the ones that can walk in and walk out. They're fast. They want the profitable patients, right? The easy patients, not people who are, like Shouldice will not take people who have diabetes and comorbidities, who are overweight. You have to lose weight if they'll do the surgery there for you.
Okay, let me get Dr. Orvan to speak to this then. Dr. Orvan, you've heard the allegation that in order to staff these new private players, you're basically going to pillage staff from the existing public system. Yes or no?
No, that's not true at all. As a matter of fact, we all know how many, particularly nurses have left the public system. They've left the public system because they don't want to deal with high acuity issues. They don't want to be put by mandatory redeployment in circumstances where they don't feel competent to look after patients. They don't want to work shifts. They want a different environment. We can provide that in the private sector with low acuity patients. There's no reason in the world why we should be doing low acuity surgeries or medical interventions in a high intensity public hospital where you have to maintain an ICU, maintain resuscitation teams and all of that. This can be done less expensively in a private institution, and public hospitals should do what they are best at doing, which is looking after the very sick and moving them through the system in a safe way.
Can I just understand? Okay, can I just understand? You just said you could be done less expensively than in a public system. How so?
Probably there are union agreements with public hospitals that require certain staffing issues that could be changed. We could reasonably use purpose-trained individuals to deliver care without having to do that with the registered nurses, for instance. So there are ways that we can in private practice where significant business decisions can be made that can lower the cost for these low complexity cases. It's very viable, and they do it in every other country in the world.
Okay, let me get Dr. Philpott on that. Do we have any reason to believe, Dr. Philpott, that if we had more private players offering publicly insured services, that there would be a flight from the public system to the private system of personnel?
I think it's a legitimate concern. I do think that, so I hear really smart points from both of my colleagues here who are on the call, and I think they need to both be open to kind of coming together and hearing each other to the extent possible. Because, Bill is absolutely right. There are all kinds of things that can be done more affordably in private clinics. And I use the family doctor's office as an example. You can provide care for an entire year for a person in a good interdisciplinary primary care clinic for the same price of one emergency room visit. So there's a really obvious example. We need to make sure that we've got great outpatient, community-based facilities that are providing good, comprehensive, accessible care to our communities. That is a more affordable way of delivering care in many cases than having people to go to a hospital. And there's a good example of that. But the kinds of things that Natalie raises are also of a very legitimate concern in terms of the flight risk of staff. But where I think we need to make sure we're identifying the correct problem. She discussed that in light of the concept of people having additional add-on fees that they are being asked to pay in order to access those medically necessary services. That's where we want to run into problems. That's not because the care is being delivered privately. That's because people are violating the Federal Canada Health Act and putting those accessory fees or the extra billing fees that actually are a barrier to access to care. That's the federal government's responsibility to be able to identify that information, to make sure that provinces are not allowing that to happen, and then actually taking the money back from provinces to the extent that they have violated the principles of the Canada Health Act. So, I think a serious crackdown from the federal minister to say this is not allowable, and if you are allowing this in your system, accessory fees or extra billing, that in fact we're going to pull that back from you, because nobody should be limited in their access to medically necessary care on the basis of their ability to pay an extra fee.
Just out of curiosity, when you were the federal health minister, how much of that was going on and how much cracking down did you feel you had to do?
I was the first federal health minister to crack down in about 40 years. I sent a bill to both Quebec and British Columbia in the order of about $10 million each in each case, because we were able to get evidence of extra billing and user fees. Both of those provinces have, well, I'm not as intimately involved with it as I am, but we got the message across, and they changed some of the plans that they were working on and made sure that, well, as Natalie knows, there are still violations taking place. But again, this is where both the feds and the provinces have to agree. Though that is the fundamental foundation of our single-tiered system. It is not a perfect system, as I've alluded to already, but there's where the responsibility lies.
Okay, let's, in case the three of you are curious as to what the Canadian public thinks about all this, we're going to tell you right now, because Angus Reid was just in the field and they did a survey and it came out just the other day. And Sheldon, maybe you could bring this graphic up and we'll share these numbers with everybody. Here we go. 61% of Canadians say healthcare is poor or terrible in this country. 61%. Half of Canadians surveyed reject the idea of more private care. 57% of Ontarians reject the idea of more private care, so a little above the national average. And about a third of Canadians say more private care would improve the system. Natalie, let me start with you. What do you infer from those numbers?
Well, I mean, it depends on how you ask the question, of course, as to how people answer. But I think the other thing is that we're talking about for-profit ownership of clinics and hospitals. And when you turn over the ownership of our public not-for-profit hospital services, the evidence is that they violate the Canada Health Act and they charge patients. If you ask the question of people, do you want to have to pay for OHIP and pay on top for private services, which is what the private clinics do, the vast majority of people would say absolutely not. And in fact, if people knew what the charges were, which are, for in BC right now, for a shoulder surgery in a private clinic, they're literally charging the patient 10 times the cost that the surgeon is paid in the public system.
What if you ask the question a different way? What if you ask the question a different way? What if you ask people, would you be prepared to voluntarily pay more if you knew you could cut your wait time in half? Any clue about what the survey would return?
If you were actually to fund the public hospitals, Ontario, for example, funds our hospitals at the lowest rate in the country. I was listening when Dr. Orvan was speaking, and I was thinking, have we really tried? We have not. In fact, we have chosen in this province, the governments in this province have chosen to fund our hospitals at the lowest rate in the country as a purposeful policy to downsize the public hospitals. We have the fewest hospital beds left per capita of any province in Canada. Canada as a whole has the fewest hospital beds left of virtually any OECD nation. We have downsized our public hospitals beyond all reason, and beyond all evidence.
Okay,
We
let me get
could
Dr.
afford
Oravan back
to
in here.
subsidize them again. We
Dr.
could
Oravan?
actually fund the public system.
Hang on a sec.
and
Okay.
provide care.
I want to get Dr. Oravan on those numbers because, Dr. Oravan, those numbers suggest to me that the majority of people agree with you that our system is not nearly as good as we think it is, but they don't seem to be embracing your notion of more private players in order to improve it. What would you say to those skeptics to get them on board?
Yeah, so what I would say to begin with is that, the total amount of money spent on healthcare in Canada in 2021 was about $310 billion. The other panelists here have identified some areas where a few dollars were spent inappropriately. That should not be allowed, and it should be dealt with. The Commonwealth Fund looked at 11 healthcare systems in developed countries, and on quality basis, Canada was 10th out of 11. The only one worse was the United States, and we know the problems that they have there. So there's no question that they have had the governments of Canada, of Ontario's provinces, and the government of Canada have had lots of time to address these issues, and they haven't. The number one performing healthcare system in the world, according to the Commonwealth Fund, is France. 27% of their hospitals are private hospitals, and they operate within the statutory arrangements in France and are paid the same way the public system is paid. 27% private. They have the best. We have number 10 out of 11. So no wonder people are upset. And it goes back to what Dr. Philpott was talking about. When you say private care, how do you ask the question? What does it really mean? Are you having to pay out of pocket? And the clear answer to that, based on international experience, is no, it doesn't have to be that way at all. We can do this in a more diverse system, cheaper and better.
Well, let me ask Dr. Philpott about something that's happening right next door to this province, and that is, I think it was alluded to earlier, the province of Quebec has announced during the course of the current election campaign that it wants to create 2 privately owned and operated urgent care centers with a promise, if the government's reelected, of more coming down the road, all within the current Quebec Medicare system. Dr. Philpott, any issues with that?
Well, as I indicated to you earlier, it's not how the delivery happens, it's who pays that is the important question. So there are all kinds of fantastic family medicine clinics, primary care clinics, all across this province, all across the country that are private organizations where the doctors earn their income from that. So they are there by definition private for profit, but they make sure, as long as you are not making people pay an extra amount for publicly insured services, you can deliver high quality, privately delivered care. But, again, I just want to reiterate the questions that have come up on that Angus Reid survey that you raised. One of the best answers of all, it wasn't one of the ones that you highlighted, but almost 20% of people said they didn't know. They weren't sure. Poor Canadian public, they are being ripped apart in this philosophical debate. We need to stop having this specific debate and talk about how we're going to improve our healthcare system. There are all kinds of other ways. This is a legitimate conversation, but we need to be talking about all of the other ways that health systems need to be improved by training a stronger health workforce, by increasing access to interdisciplinary primary care across the country, to be able to do the things that cost less but get more value for money. And so, I'm sure that people will continue this debate, but it is weaponized, this particular debate, often for political reasons, as you've indicated. It comes up in election campaigns and people use it as a scare tactic. Let's have a civilized conversation. Let's recognize that there is a role for private delivery. There is absolutely a necessity for us to protect the Canada Health Act, which is the foundation of our publicly funded healthcare system.
Okay, well, let me ask Natalie. And Natalie, I hope you won't think this is a smart aleck question, but I do want to circle back to something that Dr. Oravan said earlier, which is that oftentimes the private sector can provide services, publicly funded, more cheaply because, for example, they don't work in unionized environments. And your organization, no secret there, very much believes in a unionized environment. You support people being allowed to organize into unions and have that representation when they're in the workplace. Is that one of the reasons why you're opposed to an increasing role for the private sector in medicine, because they tend not to be unionized workplaces?
No, and actually, I mean, that really isn't the case. If you look at for-profit long-term care, a lot of them are unionized. For-profit home care, there's some unionization, et cetera. The real issue is the impact on patients. We have one mandate and one mandate only, and that is to protect the public interest in healthcare and to protect access to healthcare under the principles of the Canada Health Act. The issue with handing over hospital services, which is what we were talking about, to for-profit clinics, is that it risks that fundamental principle that you would be able to access healthcare based on your medical need and not based on how wealthy you are.
Okay,
In
fair
other
enough.
sectors, like in long-term care, for example, we have seen now for 20 years, we have fought 25 years, we've fought even just to get annual unannounced inspections of long-term care homes. The industry, particularly the for-profits, have lobbied against us in that. And actually, the inspections were stopped in 2018, and comprehensive inspections of all long-term care homes in Ontario have never come back again, even after, by the last publicly reported figure, 4,700 residents died of COVID, not counting the ones who died of starvation and
Right.
dehydration in absolute squalor.
No, I think we're all
we
well
have
aware of
never
these
been able
situations.
to
Natalie, you're going to forgive me. I
regulate-
got to jump in here because we're
Sure.
down to our last few minutes, and I want to make sure that I give each of you about a minute. Watch the clock, everybody. About a minute in order to respond to Sylvia Jones's comment. She says the status quo isn't satisfactory anymore. It's not getting the job done. In our last couple of minutes here, Dr. Orvan, you first. Give the health minister some advice on what she should do. If the status quo is no good, what's her next move?
Well, I would say that you're quite right. We've had this issue discussed now for decades. The Canada Health Act, 1980s edition. Maybe it needs to be updated and expanded to allow and include more private provision.
But that's nothing the Ontario Health Minister can do. That's a federal act.
Yeah,
what does Sylvia Jones have to do?
But I think she should take seriously her own admonition: the right care at the right time in the right place. And there's no reason at all that low acuity surgical and medical procedures should be done in a complex acute care center where there's transplantation, cardiac surgery, cancer surgery. We should make room for those in the public system and take out of the public system what doesn't need to be supported by all of the accoutrements
I'm going to stop
of very
you there.
sick patients.
Gotcha. Got to stop you there. Make sure we stay on time here. Dr. Philpott, advice to the current Health Minister of Ontario.
So I heartily agree that the status quo is unacceptable. This is upwards of 40 to 50% of most provincial budgets. We all have to do better in this country so that one of these days the Commonwealth Fund report will say that we're doing better. The biggest piece of advice I would give to Minister Jones is that I think every person in Ontario should have timely access to an interdisciplinary primary care team through our Ontario health teams. It should be as if you are moving to another community and you are looking for a public school. You will never have to wonder if your kid can go to public school. But right now in Ontario, when you move to another town, you have a very serious concern as to whether you're going to be able to find a family doctor or a primary care team that will see you. I think for a very reasonable amount of money, we can actually save dollars, provide better care, treat people up front, and make sure that we use all of our fantastic health workers in the best possible way.
Last 30 seconds to Natalie Mehra.
There's no question that the status quo in terms of the delivery of healthcare is broken. I mean, we have emergency departments closing across the province. We have a severe staffing shortage. I think the most urgent thing for this minister to do is to actually attract back the staff who have left, attract back the retired staff who have left, offer the incentives, get rid of Bill 124, actually deal with the workload conditions that the staff are concerned about, to get them back into our public hospitals and build capacity within the public system to provide the care that Ontarians need. I also agree with Dr. Philpott's urgency around improved primary care, which is actually what the Commonwealth report focused on as a problem for us, not hospitals at all, but actually access to primary care, which needs fundamental reform.
Okay, I'm going to stop you there. We're going to stop you there. That's our time. We are always delighted to provide free advice to the Ontario Minister of Health, and we have plenty of it from Dr. Bill Oravan, Natalie Mehra, and Dr. Jane Philpott. My thanks to the three of you for a very good and civilized debate here on TVO tonight. Thank you.
Thank you.
Thanks for having us.
Thanks.
Thank you.
The Agenda with Steve Paikin is made possible through generous philanthropic contributions from viewers like you. Thank you for supporting TVO's journalism.